We're going to get started in just a second. We're letting everybody get on and get going. So first of all, let me jump right in and introduce myself. I'm David Knight, the Executive Director for CalCAPA. It's great to see so many familiar faces today. We're really excited about this opportunity. It's a conversation that's kind of happened throughout the state with a couple of our different members. It's just a wonderful opportunity that fits right into the community action model. So I want to make sure we have plenty of time to discuss it today. But just to give you a little background, Brenda Callahan Johnson and I were in multiple discussions, and she had brought this up and said, hey, does community action know enough about how to go about this process to get involved in the enhanced care management? And she was going on about, just a little bit about how their agency is able to do it and how successful it has been. So I want to take a quick minute and introduce Brenda Callahan Johnson. Brenda serves on our board, is also executive director for Merced County. And so I'm really, really excited to have this opportunity, and I look forward to learning a lot about how this program runs. The last count we had, we understand that already maybe 3 community action agencies are now involved in this project. And it seems to be really, really well. We'd love to see, majority of all ours. And we actually just had a conversation with CSD and the state office, and they were really excited to hear more about this opportunity and how it fits into the community action model and how it can fit into each one of your agencies. So without further ado, Brenda Callahan Johnson, you want to take it away and then introduce our speaker today?
Sure. Thank you for joining us today. I'm sorry I have a little bit of a frog in my throat starting last night, but I just wanted to take the opportunity to introduce Lucas Brown, who is my Director of Housing and Community Services at the agency. He wears many hats. He runs the CSBG program, and he also runs our housing program, which extends everything from permanent supportive housing to HMIS to homeless shelters and navigation centers, and now the CalAIM program that we run, which is enhanced care management. I felt like it was a great opportunity to let the network know about some new funds that are available for work that we already do and that we do well. And the best part is it can create some discretionary income for the agency, and it's expanding rapidly, and there's tons of need, and there's a program within the CalAIM program that everybody can do, whether it's from food security to lifestyle to case management. All kinds of things are available. But Luke's going to share today a little bit about what we're doing and how we've made it successful in our agency. So thank you, everyone, for listening. It's all yours, Luke.
All right, thank you, Brenda. Again, my name is Lucas Brown. I'm a Director of Housing Community Services. So I'm just going to go over a PowerPoint today, just kind of covering the basics of the services that we provide. The enhanced care management community supports model. There's various services that fall under community supports. Within our agency, we're only providing a few. So I'm just going to discuss that a little bit today, kind of the basic overview of those services. And then going into some of the, kind of how the payment models and such that our agency and how we are able to, extend our services in the community. So I'll get started. Can everybody see the screen okay? All right, so essentially this is what is enhanced care management. It's a new benefits for Medi-Cal members. It comes from new Medi-Cal program, such as CalAIM, which Brenda talked about. It's the California Advancing and Innovating Medi-Cal. This benefit helps alliance members with complex needs to coordinate their care. And so for clients and our members, if they qualify for ECM, they're assigned to their own care team from one of our qualified providers, so that we are one of those qualified providers, but there's multiple providers in every community. So our team, we have our lead care manager, who talks with doctors, mental health care providers, specialists, pharmacists, case managers, and pretty much everybody in between as they try and help remediate some of those medical issues that clients and members are experiencing. So, basic services such as finding doctors, scheduled appointments for health-related services, manage medications, set up rides to doctors and pharmacies, finding and applying for community-based services that you need. Community-based services include support with housing or medically nutritious food. And then another component is set up follow-up care after the hospital. So when we have members exiting the hospital, whether it's a service from a surgery, it's making sure that they have the care they need to stay in their housing. Who can get ECM services? Adults and families who do not have stable housing, adults who have complex health issues and need to go to the hospital emergency department, adults who've had multiple trips to the hospital emergency department within the past 6 months, adults who have a serious mental health condition or have a hard time with the drug or alcohol abuse, adults who have an intellectual or developmental disability and also identify with one of the above situations, and adults who are eligible for long-term care services because of health condition, but don't want to stay in a nursing home or facility, and adults who are staying in a nursing facility, but would rather live at home, so vice versa. And so tying into the enhanced care management, when I talked about referring to community resources, one of those benefits tied into the new Medi-Cal benefits is the community supports, which we are also providing that service. And so, again, it ties into helping to remediate some of their complex health needs, such as which may be impacted by lack of housing, transportation, food, and such. We don't provide all of these services, but these are some of the services listed under community supports that are included with the Medi-Cal benefit. So medically tailored meals, housing transition navigation services, housing deposits, housing tenancy and sustaining services, recuperative care, short-term post-hospitalization housing, environmental accessibility adaptations, and sobering centers. And I know our community action agencies across the state in some form or another are providing and kind of touching on different aspects of providing these services currently. And so it is kind of a nice benefit that these are now kind of eligible under the extended Medi-Cal benefits to the CalAIM initiative. Right now with us, we are only focusing on 3 of the community supports. And that is the housing transition navigation services, housing deposits, housing tenancy and sustaining services is another one that we provide. Housing transition and navigation services, and what that is, it's essentially assisting in securing housing, including the completion of housing applications and securing required documentation. So all those things that you need to get someone into housing, IDs, social security cards, birth certificates, and things of that nature. And so another component is trying to secure resources to help individuals move into housing once it's identified. And so that may be working with community partners within your local continuum of care, your COC, to provide some of those move-in costs. Or as mentioned above, another additional benefit included with the Medi-Cal benefit is the deposit assistance. And so continuing with the housing transition navigation services, communicating and advocating on behalf of the member with landlords. So some of the members that we serve sometimes may have difficulty engaging with landlords, and so the case managers step in and help, communicate with the landlords, whether it's completing the applications, going with the clients to meet the landlords as they begin the process of applying for properties. And then, of course, as always, ensuring that the living environment is safe and ready for move-in. So just making sure we're replacing the members as a safe environment for them. Housing deposits is another component that we're able to do. So if there's no resources in the community from our continuum of care, no rental assistance available, we are able to pay to move individuals into housing. So we can cover their deposits, first month's rent, and last month's rent. So of course, it's to obtain a lease on an apartment or home, can pay for setup fees, deposits for utilities or services, first month coverage of utilities, including but not limited to telephone, gas, electricity, first month's and last month's rent as required by landlords for occupancy. Continuing with that, there's other components that we've been able to tap into as well, which is services necessary for the individual's health and safety. Some things considered in that may be like essential, cleaning supplies when we move clients into properties, so they're able to maintain their environment to keep it, safe and healthy. And even looking at goods such as air conditioners, medically necessary adaptive aids, or it could even be pest control or refrigerators to store food. So those are some allowable expenses that fall under the housing deposit benefit eligible through Medicaid. Something to consider here is that these deposits are reimbursed after submitting invoices. So you're only reimbursed after you submit the invoice, and each based on region, there is usually a lifetime max benefit. So for example, in Merced County, the lifetime max benefit for this is $5,000 per member. Housing, tenancy, and sustaining services. This service provides tenancy and sustaining services with the goal of maintaining safe and stable tenancy once housing is secure. That's how it's defined. Essentially, the goal is to, now that we're housing folks, how do we keep them in their housing and maintain their housing? And to do that, some services provided through that benefit is essentially working to identify behaviors that may jeopardize someone's housing. So is it they're having too many guests over, playing music too loud, could even be related to substance abuse issues, trying to address those issues so that we can prevent them from being evicted, as well as helping with their budgets, financial literacy, and connection to community resources. I want to leave it open for any questions before I talk briefly about the payment approach for ECM and community supports. I didn't know if anybody had any questions right now.
I was just going to add, Luke, just a little bit of background of how we got started with this program might be helpful. We were at our Continuum of Care meeting, the local contracted agency, which is the Central California Alliance for Health?
Alliance, correct.
The Central California Alliance for Health, which is the contracted agency that provides Medi-Cal services in Merced County, made an announcement that they were looking for nonprofits that would be willing to provide, in a nutshell, case management services for their ECM clients. How they defined ECM clients at that point was 4 emergency room visits per year. They needed basically case management to try to service these clients so they wouldn't use so much medical and there would be a cost savings. Luke got a hold of them and said that we were available to do that. He's going to get into what that included. But they agreed to that. They gave us startup money so that we could set up office space, get vehicles, whatever we needed to start up the program. 6 months of startup, because it takes a while to get clients to start getting reimbursed and you need to pay your staff in the meantime. So they gave us 6 months of startup. We started off with 4, we call them community health workers, but they're case managers. They're paid, is it $25 an hour, Luke? We pay them $25 an hour full time. They hold a caseload of between 30 and 35, what they want them to be called as customers or members, I'm sorry. between 30 and 35 members in their caseload. And then now Luke's going to tell you about what the reimbursement model is for that.
Thanks, Brenda. So the payment approach for the ECM community supports essentially comes down to you're paid per member per month. So which is based upon the enrollment you have, the enrollments in your program. So if the client is enrolled in your program for ECM or community supports, the enrollment is good for up to 6 months at a time. And it can be extended based upon the client's needs and requests. So if the client is still homeless or looking for housing or still having the medical issues ongoing and needs that ongoing support, then you can resubmit to be authorized to continuing services. So based upon that, I just put a notation here. This is not actual rates, but based upon, so the enrollments per member per month, enhanced care management, it could be roughly 400 per member per month. Housing transition navigation services, 300 per member per month. Housing tenancy and sustaining services, $375 per member per month. Clients can be dual enrolled in multiple programs. So for example, in our program, our staff were, like all of us, wear multiple hats. So members can be enrolled in enhanced care management to address their medical issues that they may be having, while at the same time looking for housing, or if they are housed, trying to sustain their housing and maintain their housing long-term. So you can have a client enrolled in both programs at the same time, which we found has been fairly common working with the homeless and at risk of homeless populations.
Just to add to Luke, the reason we don't have specific rates is because every county is different. Enhanced care management ranges from $400 to $500, depending on the county that you're in. And so there's a $300 range for the other two. But so potentially, you could be getting $700 or $800 per month per enrolled member. David's raising his hand.
Yeah, and I don't want to get ahead of you guys, but when you're saying reimbursed, this is your activities, but it's a rate depending on what county. And again, these are just averages.
Right.
And that is a fee for service model. You're not submitting reimbursements, right? And saying we've spent this much on salaries and this much on fringe and this much administration. This is a fee for service model, correct?
So one thing that I will tell you that was hugely in our favor when we went to apply for these services, and I believe there's how many providers in Merced County? 4, Luke?
6 now.
6 now. We provide the services to somewhere around 80% of the members in Merced County. And part of the reason that we've been successful is because nonprofits typically don't operate with fee for service, but you want to. Trust me, get over it. You want to, because whatever income you make above and beyond your expenses, your budgeted expenses in that program become discretionary dollars for the agency. So an example, let's say that you have a case manager, a community health worker. I want that are case managers, a community health worker that makes, I'm doing this off the fly here, but they make totally benefited $5,000 a month. And they're holding a caseload of 32 clients. You're bringing in $22,000 potentially from that care worker. Now, there's overhead and there's mileage and they have to have a cell phone, but everybody on this phone knows that that doesn't add up to $22,000. If you end that month for that community health worker with $7,000 that didn't need to be expended on the program, then that's agency money.
Yeah.
So it's very important that you understand that it's fee for service, and it's, you make a budget internally because you need to know, that you're going to get enough money to pay the bills, but it does become discretionary. David's going to ask a question.
And so to clarify, this is the fee for service, again, averages amount. And when we were talking about the services in the first few slides that are maybe direct services to the client, that's not included in this, right? That's what they're have access to because they're a member. And so those other actual.
Right. So if you do deposit assistance, you invoice essentially Medi-Cal separately. If you buy a refrigerator, you invoice them separately. These are just for the case management services. So even if you only did one of these, when you're talking about a caseload of 30 to 32, and this only is required one contact a month. So some people obviously are going to contact you a lot. But in order to draw this down, you only have to contact them once a month. So anyway, I was just going to explain the fee for service because I think that's a really critical part for community action agencies because we don't get this opportunity very much.
I want to throw it back open to questions for Lucas and Brenda again, but before that, we had one submitted earlier that was, do you see a change or have you seen a benefit, Lucas, around all the other programs that you already operate? So these are folks, if they qualify for this, they're probably qualifying for a slew of other programs that you're able to administer at the same time. Have you seen a benefit to that already?
Yes, definitely. So we've been able to tie this work into providing additional service to clients at our D Street shelter. So, typically within the shelter models, it's difficult to always provide all that funding for the staffing. So this allows us to bring in staff that can come in, provide that additional support to work with clients who are typically hard to work with, get them set up with their medical care, as well as other community resources, and kind of navigate them through that entire process and provide more of that kind of hand-holding that typically a lot of members who are living on the streets wouldn't receive. And so that's an additional benefit to us there, as well as I would say, we've noticed that with all the ties in exactly to the housing is key and, all the work that California is doing, they're building a lot of housing, they're housing a lot of people. How do you provide the supports in housing? And this has been a great way for us as an agency, for other partners that are building this housing have reached out and said, hey, will you be the lead service provider on this project? And so it's allowed for more collaboration throughout the community and working together. And so providing more services at the same time, being able to do the things that Brenda is talking about, we have a little more flexibility with the discretionary dollars to be more creative within your programs.
That's amazing. Just to make sure everybody saw in the chat, there was a question from Biz about is 32 members per community health worker best practice, and Brenda's answered anywhere from 30 to 40. So the question is that's what's manageable, I guess.
Well, best practice is probably always lower, but the reality is this has to be finance based. Sure. So what we're seeing throughout the state is 30 to 40. You want to have some cushion in there because there might be people that drop off during the month that you can't get a handle of. So 30 to 40 has been manageable. We started off with 30. I could tell you this, I think they're at 32 right now, Luke, or more.
35 because of the flood in those clients.
So I can tell you this, we've been doing it since January and they're actively doing it. We started earlier than that, but actively doing it. And they're begging us on a weekly basis to expand. We started 2 more staff this week. So we have now 6 case managers in our support in a new supportive housing complex that we're going to operate that has 90 units. They're building us out 5 additional office spaces in that so that we could expand another 5 case managers. They've now come to us and want us to help with young children, which we're undecided about, but that's another conversation. Be great for Head Start people. So we can't, in our county, we can't expand quick enough. There's people on the waiting list that need the services, and we were filled within 3 months.
Wow. And I heard you said earlier, I'll make that point again, that they also provide a 6-month ramp up that really helps lower any risk to kicking it off. And I think we always think about risk and fee for service, and that seems like it really helps lower the risk for our agencies.
We were actually drawing down money at the same time that we had ramp up funds.
Wonderful.
So we were afraid that it would take a really, really long time to ramp up, but they started sending us lists and lists and lists of people, prior to the 6 months. So yeah, that's at this point, the sky is the limit. And if you're competent, you can rule the world.
That's great. Lucas, you're going to say something else. I had a question for you too, as well. Is, the list of activities, kind of went through them. Is that some of the normal activities that you just see in a month when you talk about those things? I mean, obviously providing resources and having those from different angles, but really it's just about ultimately getting folks things that they need to stay housed and stay healthy. And that's your overall focus. And if you can kind of give us an idea of what the activities are, if you have any examples.
Yeah, no, so those are the basic activities listed, are the services provided that it's standardized across the state. And so one of the links you posted will take you to the the Department of Health and Human Services, or their website, where that's will tell you kind of the parameters of how this program's to operate. So there's policy guides in there, and it lists all the services by step you should be providing if you operate these programs. So when my staff comes to me like, I don't know if I should do this, Luke, well, what does the policy guide say, right? Let's direct you back to that. If it's not falling in that realm, you probably shouldn't be doing it. So, you do have that link there as well. And then it comes down to working with your local, your payers, right? So for us, we work with Alliance, but some counties have multiple payers. So that gets kind of complicated to balance that out. So, and some of it comes down to the payers as well, and what they're willing to, kind of tailor to a little bit to what their needs are too. So it's kind of there's the overarching what the state says, and it gets down to local level, and you kind of work with your payers more so, but it's fairly defined on those policy guides, and you posted that link.
Mary Alice, I see your hand up.
I was just going to ask, thank you, Brenda, for bringing this. We are also involved locally with our providers. And I think one of the things that we haven't really started it. I don't think anybody's really started it. We've been, having basically conversations with Anthem and HealthNet and all of those folks. The biggest concern I had is the Medi-Cal billing. So how did you get the training for the Medi-Cal billing and the coding that has to go with this? They haven't provided that here yet.
Yeah, so we were trained through Alliance on the billing and expectations. And so there were just training videos and webinars on that, multiple training videos. And so they lined out step by step what we were supposed to do, including the coding and what coding was expected. And then the coding is honestly fairly limited compared to like what you might see in a primary care practice. For this, the coding isn't too complicated. And so it makes it a lot simpler for nonprofit agencies to implement this locally. And so they've kind of tried to simplify that process. And now when it comes to the invoicing and billing, that is always can be a headache. And so they have multiple options with us in Alliance. There was a manual way to do it via spreadsheet, which was awful, very time consuming. But what's tied into some of these incentive benefits, and David, you can share that link with the group, or they can apply for these dollars to initiate their programs, was, looking at what software systems are out there to where you can actually do like automated billing on a monthly basis. So we work with a platform called Unite Us, to where our team is just automatically putting in the claims and invoices, and it goes right to Alliance for review. So it's cut back drastically on our time regarding the invoicing billing. And so that was something I worked pretty hard, got that set up front, because I knew that would be a burden on our fiscal staff. I didn't want to overburden them. So that was a way that we could save time on the invoicing and billing.
And they also assigned us somebody that was totally dedicated to us for billing questions, concerns, problems. So that was a great partnership, because they knew that that was going to be a hurdle, and they didn't want people to drop out, because they need us as much as we need them. And come to find out, a lot of community partners aren't that competent. I know that's a surprise to all of you, but you know, there's a lot of community partners that aren't competent. And so they really need us, because we have that history. And so they assigned someone directly to us, and they did multiple and continue to do weekly trainings.
There's one question in the chat about the Unite Us. Is that a system you had to purchase?
It was free.
Wow.
So that system was free through this partnership with the CalAIM initiative. So we didn't have to pay for that. And at this time, I don't see any fees in the future either. So
I want to open the floor up, continue with some more questions if you guys are willing to take some more questions.
I also, while you're thinking of questions, wanted to mention that there's two ways to get members. They want us to call them members, and that's different. We have all kinds of different terminology, but they're members. You can actually get members from the services you provide, because your members will qualify, and they send you members that they've identified that qualify off of their books, whoever your local contractor is. So you're never going to have a shortage of people that qualify for the program. Your biggest goal is going to be to get a leader of your community health workers that makes sure that there is a very clear understanding that this is a production-based contract. So they're not going to get to sit at their desk and do their work if they're not busy. If they don't get to 30, members within a certain amount of time, then they won't make it in the job, because it's production based, and you have to make sure that they're billing at a level in which you can sustain the job and help your other services. So that's a little bit different in nonprofits because it's production based. But I'm going to tell you, you get way more people that need the service than you're going to ever be able to serve.
And I want to acknowledge, I saw Tammy Chandler on here in North Coast. You guys have been pretty involved with this as well. I don't want to speak for you, but I know you guys have been moving pretty forward on this. I know Patty had reached out to me before about you guys working this, and so I don't know if you had any other comments as well.
No, thank you, David. I put in the chat, and I'm just so grateful for you hosting this with Brenda and Lucas, because I actually called Brenda when you both were back east at conferences, trying to get this kind of info. So it's really exciting to hear what you're doing. I did put in the chat if we could get a copy of the job description, because we're trying to update our job descriptions to really make sure we have some case management job descriptions, but really making sure they have some of that production-based language and strengthening the job description language, like Brenda was saying. And then really appreciate hearing more about what data systems you're using, because for us, that's a big part of what we're using capacity building grant funding for, is just to strengthen our technology for CalAIM, and then also for universal screening and referral that'll enhance all of our programs, like you and Lucas were talking about earlier.
Awesome. Thank you.
And I was just going to add that many of you, because of all the homeless and housing money that's been hitting the state, are getting Project Home Key, which is the motels that have been converted into permanent housing, a lot of developers that are coming into your communities to develop low-income housing. Most communities are getting a big spurt in affordable housing and homeless housing in their communities because the state has supported that so much. You can be the provider in those new housing developments with this ECM. What we know is if they're going into Project Home Key, same difference, different length of time here, that they are going to qualify 99% for this ECM. These providers want you there. These developers want you in their housing complex because they want somebody they can go to for case management. If they're, calling the doctor too much, if they're, doing inappropriate things at the development, they want case managers. So they will build out office space to get your support. And, here's something that we're batting around that's just an idea. But because we have discretionary money, we're fixing to move into a 90-unit complex. That's where they're building us the 5 offices for our new case managers. We're going to host monthly dinners. And you know what? For the people that don't show up for their case management or that are hard to get rid of, not Freudian slip, hard to get a hold of, they're going to show up at the monthly dinner, and bingo bango, you just got your monthly contact because that case manager is going to laser in on them and say, how's it going? Where have you been? What could I do to help you? Glad you got a healthy meal tonight. So for that $15 investment, you've just secured. And here's the other thing. If you're giving out something, and let's say some people in that complex are with another provider, and you've secured the office space because you've been early to the punch, and you're the one on site, and you're the one providing monthly activities or peer group or dinners, they're going to dump the other provider because they're going to want to be part of the group that's on site and providing these things that all their peers are going to. So, there's a lot of ways to do this, but I would just suggest, we're getting calls at least once a month on potential new housing developers that want us to be the service provider. And at this point, we're researching the possibility of buying an office building because we're going to have so many case managers. We can no longer support that many case managers in our offices. We're going to be busting at the seams. So that's how quickly the program is growing for us.
Thank you for that. Any other questions, thoughts? It's a good chance to get as much information as we possibly can on it. Biz, I see your hand up.
I just want to thank Brenda for doing this and David for you organizing it. We are just starting with our local CenCal group, which is the provider for Santa Barbara and San Luis Obispo. We're just getting started, but this really gives me hope that we're going to be able to work it as well. So thank you, and Lucas, Brenda.
Yeah, definitely. And Linda, I see your hand up. Thanks for that, Biz.
Yeah, this is so intriguing, you guys. We have a bunch of affordable housing units, and we work with a bunch of providers in the county who provide case management, maybe through the VASH program, the Veterans Program, maybe through a homeless prevention program of some sort, or maybe through Section 8. We've got, 2 hands worth of different funding sources that we work with. But the biggest problem that we have is successful case management. We find that the majority of those being paid very nicely in our county for case management don't provide the service to the tenants. And so I put a question in the chat on how your program interfaces with other case management programs? Do you find that you kind of take over and then you don't need those others, or do you work together with them, or how does that? I would love to put them out of business. I totally, I mean, the problems that we have are just too many to name.
We typically kind of take over. So let's say if we work with a rapid rehousing provider, right, we may help get all the documentations and together and ready for the client, and work with that case manager to identify housing. But for the most part, once they house the individual, we pretty much take lead. And so we just found that, for us, it makes more sense to kind of take the lead, and just get it done, just because of capacity issues with other agencies.
Well,
and then we do weekly we're doing bi-weekly meetings too around the housing initiatives we have here, where we're working in collaboration with the case managers. But it may be like, hey, rapid housing provider, how about you pay ongoing rent for a few months, and then we'll pay the move-in costs. So we work in collaboration that way. But once they're housed, we pretty much take the reins.
Okay, good. That's good to know.
And it's just starting to be encouraged by our continuum of care. So we're doing this service, but now, and this is, secret. Nobody can know this now, right? Real secret platform here. But they're approaching us about taking over all the rapid rehousing dollars and the supportive housing funds for the county, because it makes sense that we, don't have to work with other case managers, but it also was easy for them because they come and look at us and we are competent and we do good audits and we keep good records and we report and we're able to sustain. I mean, we have people that took over this program in the county that are in the red because they're absolutely like not seeing enough people or not billing right, or, closed 3 days a week or whatever the heck they're doing. So a lot of nonprofits, they have a philanthropic arm and not a business arm. And, I've always said to my staff, program problems are fixable. Fiscal problems are deadly. Well, we have both. So we have programmatic, aptitude and fiscal aptitude. And so as a result, we're having conversations of, how much are we going to piss off partners by taking all the money, because we're going to be a monopoly.
And one thing to consider that I have noticed a trend with those providers that are struggling is they're only doing community supports and they're not doing the enhanced care management component. I think a key reason that we're successful is we're able to wear those two hats at the same time and say, we'll do the community supports, but at the same time, you have a lot of the clients in our shelters have health issues. Well, clearly we're going to enroll you in both at the same time. And so therefore you're getting those additional dollars coming in, which is fiscally makes a lot of sense with some of the other agencies just haven't done. And I'm not sure why, but that's what's led to some of our success as well. So I recommend doing both if you are going to do this.
Paz, I see your hand up.
Yeah, hi, everybody. Good to see you. Bus with Community Action Board in Santa Cruz County. Just a quick question. Santa Cruz County has a big undocumented population. Is there limitations for them to apply? Or who can apply?
You are able to help undocumented individuals.
Okay.
And
Good to
just
hear.
side note, Paz,
Yes.
I heard from a bird that your contracted agencies in Santa Cruz are doing crappy, which is fabulous for you. And you guys have the alliance as well. So our Central Valley Alliance has Monterey, Santa Cruz, and Merced counties.
Okay.
So, I think there's some openings in Santa Cruz County based on what a little bird told me.
Nice. Thank you, Brenda.
Tammy, I see your hand up.
Thank you. I just wanted to ask if you've been successful. At first you were taking all of those referrals from the Alliance, you said, for individuals they had identified as high utilizers of hospital services. But now with your homeless services and other things, are you able to refer to them that you want to get someone into the program? And how has that worked for you, referring people in for them to pay you for that are existing clients? Because we're really trying to do that in reach for existing clients, as our managed care plan isn't quite as far along as the Alliance.
So as far as the in-reach component, what I did was I just sent my staff down to our shelter and we identified individuals that were on Medi-Cal who were potentially eligible, and we engaged them all and outreached them, and those who were interested, we enrolled them into the project. And then another thing that kind of benefits us as well is we are also the CES administrator for coordinated entry. So we have a good list and identified individuals throughout our whole county who fit the criteria for this program. And so that kind of helps us, also being the HMIS administrator, to quickly identify individuals who would be eligible. So we work with our partners to say, hey, is this person here? Can we come talk to them? So we engage with our partners that way too. So we kind of use a lot of different avenues to identify these people to do good in-reach, and then also identify people in the community who are eligible, outside of getting members who are getting referred to through Alliance.
And so to enroll them, you just do a referral form to the Alliance, or is it pretty straightforward, just a form you fill out to get them approved for Medi-Cal payments?
It's literally a 3-page form. And that's for Alliance. Now it depends on your payer. So it varies per community. Ours is fairly simple. So it just has the eligibility criteria on it and that they're requesting services. We send it in. One thing that was added in addition to this is for community supports, Alliance or your payer has to be able to get in touch with them to confirm services. So that was, can be tricky for someone who's homeless, right? So my staff just calls the payer. That just happened, Brenda, just letting you know that. So what my staff does is they reach out to Alliance directly with the member there, and we get permission there with Alliance and the member together and do the enrollment. For ECM, that's not the case. Once they're identified as eligible, it's fine. Community supports, that is just another little component that they add.
So Linda asked a question about case management. In all transparency, we required a college degree. I don't know if that was smart or not. We thought, well, at least we know that they could write effectively and probably have good orator skills. That's not always the case. Sometimes, people without a college degree are a hell of a lot smarter. And I have many college degrees, so I'm not saying that, but that's the truth. I've hired a lot of people without college degrees that are smarter than me. And so, so I would say that the one place that our employees kind of struggled at first was case management, because it's very diverse. The people that we're dealing with are anywhere from you never hear from them to you hear from them every hour, so it's hard. We were able to find some free or very, very, very low cost case management programs online that kind of give a template and a process. Luke works very well with just setting up scenarios and talking through common, things like, one thing example was, what are you going to do when you go into somebody's house and they're very stressed because their family's moved in on them and it's against the lease, but they don't want to say, so what are some case management techniques? What are some case management techniques when somebody's not participating and they're lonely? So we kind of go for the low hanging fruit to make sure. But, it's a lot of interaction. It's a lot of talking. This is kind of a funny story, but it's not funny. These are college educated young people that we've hired so far. And, one of them came to Luke and asked where you would get somebody's social security card in Merced County. They did not know that you go to a social security office. They assumed that that there was something else. Then we go to the post office for like a passport. So there's some things that we've kind of been surprised that people don't know. My point being is you can teach case management. You can teach case management as long as people write well and can orate well and articulate what they're thinking and have common sense. No, there's no AIM case management program.
Any other questions? If not, I'll give everybody a minute, but Brenda has graciously offered that you could call or email, and she dropped the email into the chat to reach out with other questions you have along the way. I do want to take a moment and say thank you again to both of you, Lucas and Brenda, for y'all's time to put all this together and take a lead on this. Like I said, I think we have about 4 agencies across the state so far, and ultimately it just fits right into what we do, and it's a great opportunity for us to take the lead on it. Here in Sacramento, we've been talking about our ability to really maximize what they're looking for and the return on investment with that. And we hope as time goes by, we're able to really show that there is a good cost to that, that's lowering the cost that they were having in other services. So if there's no other questions, we'll cut it off now.
Now, just a really quick question, sorry. So I just went into the chat and I noticed the attachment of DHCS. Can you let me know what an X means and what the date means? Because I notice there's X's on the some other criterias, and then there's dates. What is the difference?
On which link is that? I'm sorry.
That's in the chat. Somebody put the what is it? The CalM Community Support Managed Care Plan elections.
Yeah, so that basically the X's are meaning that they provide that community support, so that healthcare provider, they do that. And so,
Okay.
and then you'll see a date, and that's their planned date of implementation. They plan to
Got
have
it.
it implemented by.
Perfect.
So,
Thank you, Lucas.
yes.
Thanks.
Well, thank you, everybody. If we can be of more of assistance in helping reach out and find who you need to speak to, please let us know, and we'll begin that process with you. And we're just glad to help bring this opportunity to everyone. Again, thank you to Merced for all your work. And so we'll get the presentation sent out and all the other requested documents to everybody that's registered. So thank you guys very much. Have a great rest of the week, and hopefully I get to see a lot of you next week.